The broadcast is now starting. All attendees are in listen-only mode.
So welcome to everyone. Thank you for tuning in to the third European Society of Skeletal Radiology webinar. This month's theme is focusing on the ankle joint, imaging of the tendons and ligaments, and we have the pleasure of Dr. Llopis from Valencia, Spain, addressing the main lecture topic. We also have Dr. Perez starting us off with a case presentation, and Dr. Ereño on behalf of SERME. At the end of the webinar, please stick around. There will be an opportunity to ask questions from all of the speakers. So, no further ado, Dr. Ereño, over to you.
Okay, thank you. Good afternoon, everyone. Thanks to ESSR for this invitation to take part in this interesting webinar. My name is María José Ereño. Currently, I am Vice President of SERME. SERME is the Spanish Society of Musculoesqueletal Radiology. 21 years ago began the adventure of our society, driven by a small group of Spanish radiologists to share experience in musculoskeletal radiology. For many years, SERME meetings were to review and discuss cases. Since 2008, SERME meeting format is based on a formal meeting that continues today and also an ultrasound course every year. Every February, SERME Congress is taking place at a different Spanish location. Next year, SERME meeting will be delivered in Tenerife. In addition, our ultrasound course will take place in Granada this week. SERME currently has 463 members, most of them numerary partners. Although the number of residents is important and we have been growing every year. We also have international partners, technicians, and 5 honorary partners. The contribution of SERME to ESSR is significant, providing 275 partners to European Musculoskeletal Society. At the moment, the team of Spanish radiologists is the largest in ESSR, result of close collaboration between SERME and ESSR since 2013. Finally, it has been a pleasure for me representing SERME to address all of you today, introducing this interesting session. SERME supports projects like this one. Thank you very much for your attention.
Okay, well, I think I will start with the case. Good evening, everyone. Thanks, Dr. Dalili, Dr. Llopis, and Dr. Ereño. The following case is not a difficult case or rare case, and the purpose is to highlight some facts about the ankle instability in elite athletes. So let's begin. The case is about a 24-year-old man, professional soccer player, with an acute ankle trauma during a game. We really don't know what was the mechanism of the trauma. And the physical examination shows swelling, tenderness, and also pain on the medial and lateral side of the ankle. The AP and lateral X-ray view made the same day of the trauma was reported as normal and rule out any kind of fracture. 3 days after the trauma, the orthopedic surgeon requests an MRI and also an AP stress X-ray view. As we can see in this stress view, there is an increase of the clear medial space, and retrospectively, we can also see in the previous X-ray an increasing of the distal tibiofibular space. This clinically and X-ray findings suggest that there is a medial injury or injury of the deltoid ligament and also a combined tear or combined injury in the syndesmotic or distal syndesmosis joint. So the MRI shows in the medial side edema and a tear of the deep anterior tibiofemoral ligament, and also a tear in the superficial component of the deltoid ligament, particularly the tibiocalcanean ligament. The axial view in the white arrow and the red arrow shows this the tear of this ligament, as well as the coronal images. In the lateral side, we can see in this axial proton density fat suppressed images a high signal and discontinuity of the anterior tibiofibular ligament with the showing or with the black arrow, and also a tear of the interosseous ligament in the dashed orange arrow, and a partial tear of the distal or the posterior tibiofibular ligament. It's important in elite soccer players or in elite athletes that when we have a combined injury, a deltoid ligament injury, and also an injury in the lateral side of the ankle, that the treatment is different. Usually, the treatment in the medial side and isolated deltoid ligament injuries are conservative, as well as the syndesmotic isolated tears. But when we have a combined injury in an elite player, sometimes the conservative treatment fails. So it's preferred to perform surgery. This patient went to surgery and the deltoid ligaments was reconstructed, as we see in the images, and also two cannulated screw was placed in the distal tibiofibular space for the arthrodesis of the syndesmosis. We can see in the X-ray in the middle that we have the screws, and also we have the anchors after the repair of the deltoid ligament. Sometimes the surgeons use suture buttons, and the result is practically the same for both for this type of surgery, or for both types of surgeries. 4 months after the surgery, we only for teaching purpose only, we perform an MRI after the two cannulated screws was retired, just for show how the superficial and deep component of the ligaments are okay and are repaired. This patient, 6 months after the surgery, has a fully recovery after a long period of rehabilitation. So now we're going to discuss a few theoretical facts about the deltoid ligament. The deltoid ligament is the primary stabilizer of the medial ankle. And the composition of the deltoid ligament today is considered to be 2 layers, one superficial and one deep. The deep is formed by the anterior tibiotalar ligament and the posterior tibiotalar ligament. Usually, the anterior tibiotalar ligament is inconstant, and we cannot see sometimes in the MRIs. And the superficial component from behind from back to forward is formed by the tibiocalcaneal, tibiospring, and tibionavicular band. In this image, we can see the normal band, tibiocalcaneal, and in the right one, we can see the normal tibiospring band. The tibionavicular band is not shown in these images. So we have to remind that functionally, the deltoid ligament is the most important ligament of the ankle, especially when we have a combined injury in the lateral side. The usual mechanism of injury of the deltoid ligament is similar to syndesmotic injuries, involving external rotation of the foot or eversion of the talus within the ankle mortise. Also, the deltoid ligament injuries isolated, or the tears of the deltoid ligament injuries isolated, are uncommon and represent less than 5% of the ankle ligament injuries. Usually, they are more painful than lateral ligament complex tears and are more prone to chronicification. And the associated injuries include the lateral ligament complex injuries, the syndesmosis ligaments injury, sprain ligaments, and also flexor retinaculum. I just want to say that X-ray usually is the first method that we use to assess instability, or the first method we use after sprain is a sprain in a patient. But in the case of the deltoid ligament, the increase of the medial clear space does not predict the deltoid ligament injury. So we can have a normal X-ray with deltoid ligament injury, and we can also have an increase in the medial clear space with a normal deltoid ligament. Usually the cutoff values are a clear medial space greater than 4 millimeters, or a difference between both ankles of 2.5 millimeters. So the importance of this is that MRI is the best method to assess deltoid ligament injuries and all injuries of the different complex ligament ankles. So there is important to assess and to look injuries on the lateral side when we have a deltoid ligament tear, because this associated injury can change the treatment. Here we can see a few more examples of deltoid injuries. Here's a edema and tear of the deep component of the deltoid ligament. And in these images, we can see a multiligamentous injury in a patient, also a soccer player, with tear of the the deep component of the deltoid ligament with osseous bony avulsion, as well as tear of the anterior tibiofibular ligament, and also a tear of the anterior talofibular ligament. So in conclusion, deltoid ligament injuries are uncommon and underdiagnosed, and most isolated deltoid ligament injuries are treated conservatively. But the coexistence of osseous or syndesmosis ligament injuries can critically destabilize the ankle, and in these cases, the surgery is the choice, especially when we talk about elite athletes.
Okay, I think we are ready. Good afternoon, almost evening. Welcome to the webinar on the ankle. I took the liberty to change only to ligament and its complications because it was too long. I'm Eva Llopis from Valencia, and you have heard the wonderful presentation of my colleague and friend, Dr. Perez. During the following 20 to 30 minutes, we will cover technique and the different anatomical parts. We have divided them for educational purposes, but as you can imagine, they do interact and act most of the times like a combined structures, and we will finish with some complications. I want to highlight this wonderful paper of Dr. Golano from 2010 that I think you should really take note and review it. Most of the anatomical images are from this paper. Okay, so first start of which techniques do we have to study the ankle. The first imaging method is the plain film. And we as radiologists should know also the Ottawa rules, which are the indications for plain films. Remember, bone tenderness at the posterior edge of the lateral or medial malleolus, inability to weight bear, that means walking more than 4 steps, both immediate or in the emergency room. We have to do 3 different types of plain films. Anterior-posterior film, which is done in a non-wearing film. The talus is slightly in external rotation. The lateral gutter of the ankle is partially obscured by the lateral malleolus and the anterior tubercle of the tibia. The mortise view is obtained by internally rotating 15 to 20 degrees to bring the talus into a real, true anterior posterior, and the talar dome is nicely seen. And then finally, we'll do a lateral film. It is important to realize that the lateral and medial space should be almost as the distance between the talus and the tibial plateau. So remember, the clear space, which is this clear radiolucency space between the talus and the medial and the lateral, should be equal to the talus to the tibial. Okay, what about MRI? We always start with plain films, and I have to say that ultrasounds are also a wonderful technique to study ankle ligaments. However, has some problems to depict deep structures and bone marrow edema. MRI is a squishy techniques to see these anatomical structures, including ligaments, bones, and tendons, but also has some problems. The different volume of the structures with air in between makes it more difficult for MRI. Remember the magic angle phenomena. That means when the structures, tendons, or ligaments are oriented in more than 55 degrees to the magnetic field on short TE sequences, can show false increased signal intensity. You have to change to a long T2 weighted images, and especially in sagittal, to be able to rule out this false image. And alignment depends on positions. What have we have to do, as in other joints, a combination on plane and sequences, including T1 and fluid sensitive images. Additional planes have to be added for some areas like in the Lisfranc joint, and we can also do some microcoils for some high resolution areas. I recommend to check the ESSR website to check the protocols published on the subcommittee of sports. We will start with the axial plane that should cover from the tibial plateau to the fascia, plantar fascia. On the coronal images, we will do perpendicular to the sagittal plane, and we will include from the Achilles tendon to the navicular or cuneiform joint. The sagittal will be taken with a 19 degrees of orientation with the axial talocalcaneus joint. Only a few words about MR arthrography or CT arthrography. It's quite easy procedure. We do it under fluoroscopy guidance in aseptic conditions, and we have to put the foot on a lateral position. We marked the arterial pedia, and we should target medial or lateral to the anterior tibialis tendon. As we do CT and MR arthrography together, our dilution includes iodine and gadolinium dilution. The indications are quite limited. It's not really very essential for ligament injuries, only in some acute injuries of elite athletes, but it's very useful for chronic pain in impaction syndromes and some condyle staging. So we have to remember there are some normal findings that we should not mistake with pathological. And one is that the syndesmotic recess, it's normal. There is some fluid going up to 1 centimeter over the tibio-talar joint. Also some connection with the flexor pollicis longus or flexor tendons. It's normal and it's frequent up to 25%, and also to the subtalar joint. We don't do in our department indirect MR arthrography, but if you do it, you have to remember that intravenous gadolinium should be injected 15 to 20 minutes prior to the MRI. So we're going to start with the tibiofibular syndesmosis. The ligaments of the ankle are divided in lateral, medial, and tibial syndesmosis. The syndesmosis complex is formed by 2 bones and 4 to 5 ligaments, and I will explain why 2 or 4 ligaments. These are the structures involved: interosseous ligament, anterior tibiofibular ligament, posterior tibiofibular ligament, transverse ligament, intermalleolar ligament. Remember, it's more frequent than we thought. Up to 11% of the ankle sprains have also tibiofibular syndesmosis problems. And 1 millimeter of widen in a mortise view decreases the contact area on the tibiotalar joint by 42%, and that leads to instability and early development of osteoarthritis. So first, starting with the interosseous membranes that runs, let me check if I can move this. Oh, I'm sorry. That runs oblique up from the fibula to the tibia. And you see this small recess 1 centimeter above the tibiotalar joint. Its function is a spring, allowing small separation during dorsiflexion, neutralize forces during heel strike, and stabilize talocrural joint with loading. On axial plane, it's mainly seen as a small as a small dots over on the axial plane, because it's made of short fibers together with fat and small branches. The interosseous ligaments insert distally on the margins of the tibia and the fibula, forming this triangular space that we have already mentioned. It sits on MR arthrography as normal vertical contrast-filled pouch. The extension more than 2 centimeters is always abnormal. And this area should we avoid when they insert wires for external fixation to avoid septic arthritis. It's important to realize that sometimes there is some synovial tissue that can move into this pouch, and this is a normal finding, should not be mistaken, but this is also related with some impingement. Here in this example, we see very nicely how the fluid extends over the pouch more than 2 centimeters. Remember, the weakest point of the syndesmosis is the anterior tibiofibular ligament. It's a thick multifascicular ligament that has an oblique orientation that extends from the anterior tubercle of the tibia to the distal fibula. The fact of being oblique should be remembered because on reporting we should follow in the axial planes before saying that has a rupture. Some people have considered this inferior part of the anterior tibiofibular ligament as a second or a different ligament. It was called the Bassett ligament, but today we know that they are fused together with the anterior tibiofibular ligament. It's the weakest point of the syndesmosis. The posterior tibiofibular ligament is a strong ligament. Actually, it's so strong that avulsions are more frequent than ruptures. It has 2 different portions. The superficial portion, which is more posterior and superior, and the deep transverse ligament. The deep posterior fibular ligament or transverse ligament, it runs proximal from the posterior part of the fibula, going into almost to the medial malleolus, and may extend very much into the medial sides. The last ligament that we're going to review is the posterior intermalleolar ligament. It has an origin on the fibula between the posterior tibiofibular ligament and the posterior talofibular ligament. It has some different insertions on the medial side, and this is very important. So it has some insertions in the tibia, it has some insertions on the talus, but also in the septum together with the flexor tendons and also to the posterior tibialis tendon. And this is nicely seen in this MRI in this MR arthrography of the ankle. One important thing is that this posterior intermalleolar ligament tenses in dorsiflexions and relax in plantar flexion. Because it's tense in dorsiflexion, ruptures occur in dorsiflexion. But another thing that's important is that its placement, it's different between dorsiflexion and plantar flexion. And you can see this very nicely in this wonderful paper of Dr. Golano, where you see when it does plantar flexion, how the intermalleolus tendon gets entrapped between the tibia and the talus. And that explains why sometimes we can have some posterior soft tissue impingement because of thickening and fibrosis of this ligament. We're going to pass to pathology, and remember the mechanism is usually external rotation of the foot with the leg in internal rotation and hyperdorsiflexion. Clinically, there are some different tests. The first one is just pain on the syndesmotic area. The second is a squeeze test with squeezing the leg below the knee, radiates the pain on the syndesmosis area. And the last one is external rotation of the foot. The foot is turned to the outside and has developed pain in the high ankle area. There are different grading systems, but the more used nowadays is the Sikh grading system, and the reason is that it not only does a grading system but also serves as a prediction to return to sport and daily activity and establish a guideline for treatment. So grade 1 is anterior tibiofibular ligament rupture and has pain management. When adds the interosseous ligament, it needs 3 weeks of rest and rehabilitation to get back to sports. When adds the posterior, 3 to 10. And as we heard in the wonderful presentation of Dr. Perez, when it combines with deltoid ligament rupture, needs surgery because of posterior instability. We're only going to review briefly these measures that have been already mentioned. So the tibiofibular overlap is because we do the plain film, and you can understand there is some overlap of the tibia over the fibula. So on the normal AP view, this distance should be more than 6 millimeters. On the Mortase view, it only more than 1 millimeter. The measure is between the medial border of the tibia and of the fibula and the tibia. The tibiofibular clear space also has been mentioned before, is the distance between the medial border of the fibula and the posterior tibia or incisura fibularis, and should be less than 6 millimeters. Here we see three different examples of abnormal films. Here in this case, what we see is a decrease of, here we see an increase of the clear space very nicely, more than 5 millimeters. And in this case, we see that we do not have a tibiofibular overlap. The problem is that 45 to 58% of the patients with syndesmotic injuries, plain films are normal. This is why we need MRI. And although the sensibility and specificity is still under controversy, it's very well depicted the injuries as normal as usually we will have discontinuity, wave contour, and associated injuries, bone marrow edema, and soft tissue edema. We will also see as an increase of the tibiofibular recess more than 1 centimeter. And on chronic patients, as always, there will be some fibrosis and healing process. And with that, we will see some increased signal intensity, some thickening of the anterior tibiofibular ligament, the posterior tibiofibular ligament, with some hypertrophy and synovitis. And this fibrosis has been related with impingement. There's always also associated injuries. calcifications of the syndesmosis, osteochondral lesions, anterior tibiofibular ligament injuries. We also saw the medial complex injuries of the joint, some joint incongruity, and early osteoarthritis. So we're going to move on to the more frequently injured complex. This is the lateral ligament complex. It is formed by 3 different structures: anterior talofibular ligament, posterior talofibular ligament, and the last one, calcaneofibular ligament. It's a frequent injury. Up to 16 to 21% of sport lesions occur in the lateral ligament complex, and in some particular sports such as basket, more than 50%. It occurs in young patients, and usually the mechanism is plantar flexion with inversion. Most of the cases are treated conservatively, and actually they do not need imaging. However, up to 10 to 20% of the patients might develop chronic instability. And it's important to remember that they usually, almost always, follow a predictive pattern. So the first ligament that's injured is the anterior talofibular ligament, followed by the calcaneofibular ligament, and the last one is the posterior talofibular ligament. Isolated injuries are uncommon. Okay, so let's review the anatomy of the anterior talofibular ligament. As said, is the most frequently injured. And it has been, although there was some debate if there were 2 or 3, it has been demonstrated that there are 2 different bands, the superior and the inferior, with some fibrovascular tissue in between. And on MR, we see it very nicely like a thick structure between the distal fibula and the talus. And we were very happy with our knowledge about the anterior talofibular ligament. But recently, in September 2018, the same group that followed the legacy of Dr. Golano, the group of Dr. Vega, have recently described a new structure or new ligament complex on the lateral ankle. And this is, they call it lateral fibulothalocalcaneal ligament complex. And what they say is that the anterior talofibular ligament has a superior part, as we knew, and this part is intra-articular, and the inferior part, which is different, is extra-articular and is closely connected to the calcaneofibular ligament by some arthiform fibers. So there are 2 different distinct structures with different insertions, as we can see in this wonderful anatomical sample from this paper. As an intra-articular injury, it's not able to heal, and that's why it has been related with microinstability. This ligament, the superior portion, increases with plantar flexion, whereas the inferior anterior talofibular ligament is an extra-articular structure. It has a common origin with the calcaneofibular ligament, inserts more plantarly to the talar bony, and it's connected with the calcaneofibular ligament, as the calcaneofibular ligament is isometric in movements. So what's important is this might explain why surgery only of the superior anterior talofibular ligament improves stability. And the inferior anterior talofibular ligament, together with the arthiform fibers and the calcaneofibular ligament, form a functional unit, which is the lateral fibular talocalcaneal complex, and is extra-articular, so has some potential for healing, and is related with chronic instability. So now the problem is that radiologists, we have to learn how to see it, and that's what we are trying. Next ligament is the calcaneofibular ligament, and as said before, it's usually injured together with the anterior talofibular ligament, very rarely isolated, and it remains tense in all arch of flexion, as we can see here from the paper. It runs oblique from downwards and backwards. So you will only see it in one plane if you do an oblique coronal plane, like in this T1 weighted image of MR. So usually what you have to see it is on different planes, on coronal, but especially on the lateral axial plane. This is the best plane to see the calcaneofibular ligament. It has a very close relation with the tendons, the peroneal tendon sheaths. You can see it here. It's superficially crossed by the peroneal tendons and actually leaves this concavity in the tendon, and only 1 centimeter it's uncovered. This intimate relation, it's why sometimes we will see as indirect sign some fluid in the peroneal tendons. The posterior talofibular ligament is a multifascicular structure that runs from the posterior malleolar fossa to insert in the posterior lateral fossa of the fibula to the posterior lateral talus. It has some fat in between and has different insertions. This is why sometimes if people do not have experience, this fluid between the fibers or this fat between the fibers can lead to a mistake, and they might say it's rupture. Okay, let's see some examples of lateral sprains. So what are the signs of a ruptured tendon ligament? Well, as in every place, what we will see is discontinuity, and here we see nicely a discontinuity of the anterior talofibular ligament. However, remember, discontinuity is not it doesn't mean only dysfunction. Here in this warm-up case, we see nicely how it's a rupture, complete rupture of the 2 portions of the anterior talofibular ligament. We can also see some hematoma. Remember, there were some arteries of the fibular artery between the 2 bundles of the anterior talofibular ligament. And here we see in this this might be this intra-articular rupture of the superior anterior talofibular ligament. We can also see avulsions in chronic cases or acute cases. The sprain of the calcaneofibular ligament must be followed, especially on the axial planes. And this is a wonderful example. We see there is not the classic one line, black line of the normal calcaneofibular ligament. Is usually associated with anterior talofibular ligament. And the indirect easy sign is the presence of fluid within the peroneal tendons, as seen in this wonderful sagittal image on our warm-up case, that has a complete rupture of the calcaneofibular ligament. On MR arthrography, we will see the leak of the fluid to the peroneal tendons, as like in this example or this video, where you see all the fluid going into on the peroneal sheath tendons as an indirect sign of a complete rupture of the calcaneofibular ligament. So remember, fluid in the peroneal sheath is an indirect sign of calcaneofibular ligament injuries. What about chronic injuries? And we will have chronic injuries, and always there is some fibrosis of all the ligaments. We can see it here on this chronic. Sometimes we don't see the ligament, we don't see bone marrow edema, or in this other case where we see very nicely some thickening of all the lateral structures. Here you see very nicely how thick are the structures, the calcaneofibular ligament. Here you can follow it until its insertion, it's in its oblique view. It's exceptional to have a rupture of the posterior talofibular ligament and usually are associated with major ankle disruptions. Only this wonderful case of Alexys, you can see nicely some intraligamentous tear of the posterior talofibular ligament. Please do not break the posterior talofibular ligament if there is not other injuries in the ankle. I'm not going to mention the medial complex because it has been wonderfully described by Dr. Perez. Remember, two structures, deep and superficial. It's an important stabilizer, and its insufficiency leads to osteoarthrosis. And although it's infrequent, when it associates it as syndesmosis rupture, then sometimes you will have to do some surgery to avoid chronic instability. So the last part are chronic complications of the ankle sprain. Although there can be some discussions about the indications of imaging for acute ankle sprain, there is no discussion about the importance of imaging on chronic ankle instability. There has been two different types described, the functional, which occurs only during walking, or mechanical instability, that you can already see it clinically or radiological. And remember that 20 to 30% of repetitive sprains can develop chronic ankle pain. What we will see in the ligaments, we already mentioned, the ligaments are elongated, they are thick, irregular, they have some low signal intensity, do not have soft tissue or bone marrow edema, and there is decrease of the fat of the normal recesses. The complications can be peroneal complications, anterior medial or anterior lateral impingement, osteochondral injuries, tarsal sinus syndrome, loose bodies, or posterior subtalar osteoarthritis as the last complications. Starting with the peroneal tendons, you have to remember that the peroneal sheaths are very close related with the lateral ankle ligaments, are prone to injury during a sprain and a cause of chronic pain. You can have ruptures, as in this case, you have here wonderful split rupture with some fluid surrounding the peroneal tendons, or you can have also avulsions of the retinaculum. You can have a tear, or in this wonderful case where you have this wonderful avulsion. Because of the thickening secondary to healing process and hypertrophic synovial tissue can cause pain and mechanical impingement because they occupied the anterior lateral gutter or the anterior medial gutter. And this, you can understand, this meniscoid type lesion can be entrapped with movements. And MR arthrography, it's very useful for assessing soft tissue scarring. This is another example from Luis Terrassa with a wonderful case of an anterior medial impingement. Sorry for the mistake. And it's, remember, you see this meniscoid type of lesion, osteophytes, and some can have some chondral lesions associated. An important cause of chronic pain is the presence of osteochondral lesions of the talar dome. It has been recognized as more as a post-traumatic than vascular origin, secondary to sprains, more frequent in medial, and the MR role is to locate the lesion and to stage the cartilage and the subchondral bone. The classic classification is Burnt and Harry classification, but recently Griffith has also described a new classification that's more close and related with the surgeon's view. And they have, so here we have a nice grade 1 example with some subchondral edema with normal cartilage. Or in this grade 3 case where you have a partial collapse of the affected bone with some hypertrophy of the cartilage, and you can have it with or without a cartilage fracture. Sometimes you will have a separation of the cartilage, an incomplete separation with or without a cartilage fracture. Another complication is synesthesis syndrome. And remember, synesthesis syndrome is a clinical syndrome, and one of the cases is traumatic. It's described when the patient has pain and tenderness in the lateral side of the ankle that worsens with movements, walking, and supination. What do we will see on MR? We will see some edema in the synesthesis, synovitis, the loss of a normal fat plans and sometimes discontinuity of the ligaments of the synestarsis. And the last complications I'm going to show is loose body. This is a wonderful case of a patient, is a tennis player that has, as you can see, an alt avulsion fracture depending on the anterior talofibular ligament, and has some loose bodies that went into the sheath of the flexor tendons. And you can see it here, but more nicely here on the plantar side of the flexor tendons. So my conclusions is that the knowledge of anatomy is essential for understanding ankle biomechanics. Ankle syndesmosis lesions are more frequent than previously thought and a cause of instability. Acute ankle and lateral medial sprains usually do not require images unless in at least a scenario or when they have this instability. Remember, medial sprain and syndesmotic injuries might cause instability and might need surgery to avoid it. And it's very frequent to develop chronic ankle pain secondary to repetitive ankle sprains. And now we have to try to see this new ligament. I'm going to finish just trying to see if I can show you the whole case that I sent you as a warm-up case. This is a sagittal view. You can see here some plantar fasciitis and a small rupture, and this huge acute injury of the lateral side. You see the bone marrow edema on the talus, bone marrow edema on the fibula, some thickening of the intermalleolus tendon, and you can see here nicely on the axial planes, you can see complete rupture of the superior and inferior part of the anterior talofibular ligament, and also a complete rupture of the calcaneofibular ligament. And with this, I thank you for your attention.
Well, thank you, Dr. Eva Lopez, for that excellent summary on such a tricky and complex joint. Clearly, this is a topic you are very passionate about. And thank you, Dr. Perez, and thank you, Dr. Ereño. So now we have time for a few questions from the floor. So please feel free to attach a microphone and raise your hand by clicking on the hand gesture icon on the webinar panel, or you can alternatively type your question in the question panel. So do we have any questions for our speakers? So we have a question, Dr. Lopez, I think aimed at you, from a Pedro Rabaca. He's asking if the tibiospring ligament is consensual.
Excuse me, if it's?
He's asking if it's consensual, the tibiospring ligament.
Consensual means that it runs together.
Pedro, do you want to elaborate on what your question is? I think he's making a statement. Do you have any questions from the floor?
So the tibiospring ligament, it's part of the deltoid complex and runs between the tibia and the spring ligament and makes a continuous structure. And this has to be very well evaluated, not only in medial sprains. I'm not sure if that's what you mean.
Anyway, we'll have to move on. So Etienne Rabé is asking, what are the general indications for ankle MR arthrography?
Okay, so the general indications, I think the most indication is when you have a suspicious of an impingement and you don't see it on normal MR, because sometimes this fibrous tissue that seem like a meniscus, they are very thick and very difficult to differentiate from the normal structures because everything's like together on fibrosis. So that's, for me, that's the main indication. Then if you're working on elite athletes environment, then sometimes you have to see very well the ligaments. And in the future, probably because the approach of the ligament surgery is increasing, this superior anterior talofibular ligament is intra-articular and related with instability, microinstability. And what they are doing today is that surgery just on that, and only with surgery of the superior part, also stabilize all the lateral part of the ankle. Therefore, if your question is about this, in those patients that might need MR surgery, you need MR arthrography. About osteochondral lesions, I think it's more into a debate. I think with high resolution microcoils, you have most of the time enough information.
Perfect, excellent. Thank you, Dr. Llopis. And another question from Roque Oca Pernas saying, do you routinely use strict axial planes or do you prefer oblique for ankle assessment?
I mean, we do oblique, a little bit oblique, but normally axial. When we do oblique axial plane is sometimes when the question mark is about the syndesmosis, because the syndesmosis, as I showed you, it has an oblique from the tibia to the fibula upward. And sometimes if you do oblique plane for that, it's very nicely seen. In the near future, this is going to change because nowadays the 3D sequences of fast spin echo, proton density, or Dixon are excellent. And with that, we will be able to acquire isometric sequences and be able to do these oblique planes for in any single different plane that we need.
Thank you. Perfect. All right, we'll take one question from the floor if someone has a microphone. So Ahmed Othman, I'm just going to unmute you. Are you there, Ahmed?
Yes, I am. Do you hear me?
Perfectly.
Perfect. Go ahead.
Okay, thank you very much. Well, we are always, thank you first of all for this great review on this topic. We have the question oftentimes about the syndesmosis, and the arthroscopic surgeons are not really aware of the interosseous ligament. They just ask if the anterior part or the posterior part is injured or not. How relevant is the interosseous part actually for the surgery? I didn't get it.
Okay, so most of the time, this is a continuous. You will have, first of all, the anterior tibiofibular ligament rupture, and then the interosseous ligament. So it doesn't happen one without the other most of the time. Okay, so if you see the anterior and the posterior, usually the interosseous membrane, it's also rupture. It's exceptional. And you could see in the wonderful case of Alexys, I'm not sure if you remember, this wonderful axial plane where you see some fluid increasing the distance between the tibia and the fibula. Okay, so yes, most of the time they go all together. So it's in the spectrum of the injuries. It's not isolated injury.
Yes, thank you. I understood that. But is it therapeutically relevant if only the anterior part or also the interosseous part is injured or not? Because some people say if the interosseous part is injured, then they would rather do the therapy rather than when it's only the anterior part.
Yeah. So the anterior tibiofibular ligament itself, it has a conservative treatment. Okay. When it's the anterior and the interosseous, it also has a conservative treatment. When are the three structures, then there is always a question mark if it will be surgery or a longer period of rest. And that's why I'm not sure if you remember this paper of Sika.
Yes.
It was from Foot and Ankle 2012. And this is the classification. The advantage of this classification is that also guides not only the pattern of injury, but also the time to go back to sports, but also the treatment of these patients. I'm not sure if that answers your question.
Yes, it answers it perfectly. Thank you very much for your time.
Okay, thank you.
Thank you, Ahmed. Thank you for your. Where are you coming from?
From Tübingen, Germany, University Hospital. We have actually a huge surgery department which is specialized on joint surgery, and I'm confronted with these questions daily.
Great. All right. Thank you for participating.
Thank you.
Thank you.
Okay, one more question, Dr. Llopis, if you may.
Yeah.
Do you have a question about the bifurcate ligament complex? Do you evaluate them in all ankles? This is from Vibhuti Kalia.
Okay, I think the best one to answer this, Alexey, can you answer this question? Because he is a very good on this bifurcate ligament. Are you there?
He's there. He's just.
I'm here, but I was in silence. I don't understand the question. Can you repeat again?
I'm sorry.
I don't hear what the question was about.
Talia is asking, do you evaluate the bifurcate ligament complex in all ankles?
Yeah, I usually do, because sometimes in an ankle sprain, you see that the lateral ligament complex is okay. There's no tear, not edema around the ligament, and the pain is located just in the insertion of the bifurcate ligament. I usually, as a routine, I look for injuries in the bifurcate ligament and also in the dorsal calcaneocuboidal ligament. Sometimes the sprain can not affect the lateral ligament complex and can affect the bifurcate, and we can also see small avulsion of the anterior process of the calcaneus. So yes, I do it. I look for injuries in bifurcate and dorsal calcaneocuboidal ligament as a routine, especially when I see the lateral ligament complex normal.
Okay. Well, thank you, Alexys. We've run out of time, unfortunately, but thank you for those who've contributed to the discussion. This recording will actually be available in the next few days on the ESSR website. So don't worry if you tuned in late. And we look forward to welcoming you again to next month's lecture, which will be given by the previous ESSR president, Dr. Philippe Vallenacker from Antwerp in Belgium. And that will be on lumps and bumps of the soft tissue, how to differentiate benign from malignant lesions. So please register ahead and tune in on Monday, the 10th of December. So thank you for tuning in on behalf of the ESSR Young Club. We wish you a pleasant evening. Thank you.
Thank you.